If positive risk-taking was easy, we wouldn't have... Welcome. We would like to introduce to you Faye Noble,
Risky decisions usually take longer, take a lot more communication.
Gabriella Salmon,
There are very strict guidance set in place, which for the vast majority of the time is there for a good reason.
Becky Gorf,
I just think the threat of being sued worries people.
Sajida Nanabawa,
Because when I first started this job, I thought I was the only one.
Hein LaRue,
We're all scared of being criticised, so it's easier to go, right, well, there's something the hospital could do or somewhere else this person could go.
and Probjot Singh.
We're actually disabling them from being independent and physically as able as they can be.
And this could be anyone, but it's emergency doctor...
Please, I really don't have time to talk to you.
Well, and Ted Davis, 83-year-old Marvel. And
Roger.
Roger helps keep Ted on legs. Ah, Ted. Some of you have met him before. He made us laugh, he made us cry. He made us feel what it was like to be Ted. A remarkable man. Ted is still living at home with support. His son lives nearby. He's seen his grandchildren grow up. He's raised countless sums for charity. Well, Ted is back in the emergency department. Sorry.
Sorry.
My patient came into the emergency department. He was a Japanese 80s, had a fall and had some rib pain. Had a clinical assessment, checked him over, and ultimately he had a CT scan which showed a number of broken ribs, so a significant injury. And actually, some of the first words he said to me was, "I've come in, but I want to go home." He was adamant he wanted to go home, so it's a difficult decision to balance his needs and those medical needs as well.
So we know this story. Old man, I've come in, but I want to go home. Are you going to let him jump back into his life?
Wait!
Well, this is person-centred care, isn't it? What are you going to do?
Could you give me a minute, please?
Time is ticking. Oh, there are so many reasons it's hard to make a decision, aren't there? Tick, tick.
Hello? Hello?
And the average person makes, 700 decisions before tea time? Walk to work or drive, chicken or cheese, swipe left, swipe right, 5 milligrams of Oromorph or 15 milligrams of codeine, admit to the ward or discharge them home. I mean, come on, it's not that hard. This is your job. What are you worried about?
Tell me that you love me, tell me that you love me, tell me that you love me true, 'cause I've been waiting long to hear.
And it's not just your colleagues.
No one comes above me, and you always will be true.
Are you looking after my dad? It's your responsibility to keep him safe. If you're not careful, I'll sue the bloody hospital. I'll sue you.
'Cause I've been waiting long.
Do you hear me? I have your job. Are you listening to me? Hello? I'll get you the facts. I'll take you to court. Do you understand what I'm saying? My father deserves better.
Like I said, what are you worried about?
I'm sorry, so sorry.
I mean, it's what you were all thinking. It would be so much easier to just hand the decision on to someone else. You could just admit them to the ward because, I mean, what else is there? personal attitude to risk.
Stop! Come back! Be careful!
Ted still wants to do what he wants to do, though. Tick, tick.
I think people are really worried about going against the grain or giving an opinion because they're worried about the consequences. Every patient I look after, I look at them and I think, if this was my mum laying here, what would she want or what would I want for her? You've got all of your policies, you've got all of your procedures, you've got all of your hospital values, all of your personal values, everything that comes into it. But the one question that it boils down to for me is, if this was mum, what would I want?
I always ask the people that I'm looking after what matters to you, rather than just what is the matter with you.
It's about listening to them, and that relationship you have with them, you've got to build that trust.
I remember going with my mother-in-law to the hospital on her appointments, and language was always a barrier for her. And when I went with her, she would tell me exactly how she felt, and she would tell me how to explain that to the doctor. And I felt that I was able to relay back what the doctors were saying, and that was very reassuring for her.
If there are challenges around people's communication or indeed their capacity to make a decision, it's really important that we understand what matters to them. And so whilst they do have capacity, that's when we need to write down and document what's important to them, so that when things change for them, we can go back to their wishes and hopefully follow those through and give them what they would want.
So obviously you have to do a clinical assessment that took into account his pain, his other medical problems and medications, etc. And he actually had a CT scan of his chest. And actually what it showed was that he'd had a number of rib fractures and a little bit of bleeding within the chest. There's a number of guidelines and scoring systems you might use for problems such as that. But my patient was adamant. He really was very clear that he wanted to go home. I needed to communicate with him. Actually, that wasn't risk-free, that wasn't a zero-risk decision, and as long as he was aware of that and I could provide the right information and not scare him but also be really clear about that. What's incredibly important is to understand what their function is like. The age alone won't give you that information, and that really is just about having a conversation with your patient. Day-to-day life, what does that look like for you? What do you struggle to do? What are you really good at? And how do you think this will impact on you if indeed you want to go home?
I remember the first time that I was out on the ambulance by myself without another paramedic beside me. It felt quite exposed. It can be quite daunting to ask for help. You feel like somehow it invalidates all the work you've done to get to the point of being qualified. But at the end of the day, I knew that the support was out there for me.
When you're stuck with a decision that you're not sure which way to go, you can now use this app called Synapsis, and it's on our mobile phones. It just allows you really easily to link up with the specialist of your choice, and a specialist at the other end can see the patient's notes, their blood results, their investigations, all their letters, and then you can have this sort of two-way conversation. Well, I'm in this person's home, or I'm in the GP surgery. This is the problem I'm faced with. What should I do?
I would probably call one of the senior clinical team. They're available 24 hours a day, and I know that I could call them and get some really good advice and some security in my clinical decision making from them.
Working with other healthcare professionals who don't just work in emergency medicine, that's really helped me, because I see actually the opportunities in the community far more than I used to.
Lots lots of examples of care that we can offer in the community. Primary care, nurses, GPs, pharmacists, physiotherapists, mental health workers, social prescribers, our allied health professionals in the community services, again district nurses, frailty teams, dementia teams, end-of-life teams, voluntary sector organisations. There's just so many, it's hard to list them all.
And this brings us to the team of teams.
Traditionally, we've all worked in our separate teams, but we haven't necessarily coordinated our efforts around the person.
And so you think of your older relative, your much-loved mum or dad, and up the garden path every day goes a different team for each condition. That's where that idea of the team of teams comes in, because rather than us all going up that garden path, all working really frantically on our little bit of that person, actually, if we step back and think, well, let's all have a multidisciplinary team meeting and go, this is what is important to my mum or dad. Let's see how we can work together to deliver that. Hopefully you're going to get less contacts for that patient and also try and cut down all of that duplication, which isn't actually adding any value.
Well, that's the opportunity, is to try and get all those different people to work together, which is what we've got to do.
I had a lady who was a high intensity user for the emergency department. Her well-being was really affected and she wasn't sleeping. So the first thing I did was buy her a bed. She's completed a few courses with Art Shape. She's attended lots of cooking classes. It's taken time, but she's done really, really well, you know. She's not attended A&E for the last 6 months. I've provided hoovers, washing machines, sofas, fridge freezers. I'll attend their appointments with them, you know, just to support them, because some of them are quite fearful. It is like a medicine. At the end of the day, it's like having a dose of aspirin or codeine. With just having a little chat over the phone or coming out meeting, it's their table and we need to fill it.
Can the family support? It's worth asking them. There are family members that can offer more support than others. For those that can, please involve them in their care. If carers need support, there are organisations which are set up like carers hubs to give them that support, give them that guidance and give them that time out or respite.
As you become more experienced seeing certain patients, certain presentations, and your pattern recognition over time will change and actually start developing your own sense of where your risk is. And that does depend on the type of person you are, probably. We're human beings, so sometimes you'll get it wrong, and those will absolutely inform how you apply that in the future.
If you're not sure what to do, have the courage to ask for support.
Trust your instinct.
Trust the team.
It is about empowering people, so we have to look at what's right and good for them.
You've got to build that trust.
I cannot imagine doing a job where I didn't directly, positively impact someone's life.
There are lifelines and stop signs and circles where you go. The ship is safe in harbour, but it's not what ships are for. The ship is safe in harbour, but it's not what ships are for. The ship is safe in harbour, but it's not what ships are for. The ship is safe in harbour, but it's not what ships are for. Take telescopes for hope and chemicals to flow. Find a way in what you know, a way in as you blow. Cut cross, cut rip and roll. Cut the line and call the no. Let lifelines and stop signs and red lights and work life and telescopes and chemicals and circles where you go. The ship is safe in harbour, but it's not what ships are for. Take a shot, safe in harbour.
The producers would like to note that our own positive risk assessment had to consider a puppet made of paper in a swimming pool in February. Nobody said this stuff was easy, but just sometimes It's worth it.
But it's not